Okay. All right. Well, Martin, so we're not expecting anybody else from your team?
No.
All right. Well, Martin, do you want to start with an introduction and interest in this meeting?
Yeah. So my name's Martin Sanchez. I'm the population health supervisor here for Greater Health Now. And in August of 2022, we started we started to contract with 10 fire departments that we identified throughout our 9 county region to help them either grow a program that they already have or uh, just implement one, either a community paramedicine, mobile integrated health, or a community-based care coordination. But those those meanings kind of intertwine with each other. So we'll just call it community paramedicine programs just for us. So there are some that have a program in place already, but most of them don't. And that's because they're small fire departments, they don't have resources available, but they know that the need is there in their community. So this is giving them an opportunity to tackle those issues that they're seeing in their communities. High utilizers of the 911, high utilizers of the ED, those that are being re-hospitalized after they have gone back to their home. And there's those that just need they just have a need. It might not be physical, it might not be mental health, rather more of like, hey, I don't have reliable food source, so let's connect them to Meals on Wheels or something. So the the programs that we are using a model that was previously used for practice transformation cohorts, which was very clinical. So it included primary care, hospitals, behavioral health, SUD, a dental clinic, urgent care, skilled nursing facilities, but no fire departments. So the milestones that we developed for those cohorts, the language in there is very clinical, like empanelment, risk stratification, shared decision-making tools. There's a lot of the language. While we were presenting it to the fire departments, they're like, how does this fit for us? So so we use that same model for the fire department. So I kind of had to translate pretty much all of the questions into language that they would be able to understand, like empanelment. They didn't really know what it was, which is to them, how I explained it is your group of people that you're working with for this program. So they're empaneled to you guys until they graduate or they no longer need your services. But that has been a little bit tough to kind of, because when I'm not there, they're like, well, what is this? I know he went over it with us, but they just don't they forget it because they have a lot of things going on. So talking with Eric and the rest of the other ACHs, Eric mentioned that you guys are using for the your guys' program the charge model, which was developed specifically for that. So I was just curious to kind of see how you guys use it, how it's being utilized by the fire departments, and kind of how the reporting works, or if you guys get the reports from the fire departments using the charge model to kind of make sure, hey, this is what we're doing, this is the data that we're capturing. So I'm just curious to see if it's working for you guys. Why not use it for our region as well, because it's already working for fire departments in your ACH. So that was my curiosity and the purpose of this meeting, just to review the charge model that you guys are using.
Thanks, Martin. We'll just go around and introduce as well. Sam, do you want to do a quick introduction, and you'll steal the show here in a little bit with the charge model and background.
Yeah, again, I'm Sam Lewis. I'm a social worker for the Cowlitz Fire Rescue here in Clark County. We serve Clark County and then southern, like a little piece of southern Cowlitz County. I'm the community outreach coordinator and really helping spearhead the charge model, but really from the inception of the program, looking at forums. And again, we can talk a little bit kind of about our process of how we ended up at this point, because I definitely think the program itself and how we're doing it has changed over the few years. especially with some of the translation from the fire department to us. I come from more of a clinical background when it comes to more mental health and social work and all those.
Mhm.
And so a lot of the forms we were thinking originally, again, were from that vein, which sometimes don't work with everyone else. So
Yeah.
it's definitely a period of translation that we definitely had to add, not just between the two cultures in here, but then even between how do we even document in a system that previously wasn't being used for that also.
Yeah, it's been a great partnership with Clark Cowlitz Fire and Rescue and Sam. And really, I would say it's been just a full-on transparent test of change partnership where we've the program, as Sam says, has really evolved a lot. We've been privileged to be able to work closely with Clark Cowlitz Fire and Rescue. At sometimes we were meeting weekly, now we meet bi-weekly to really support our own understanding of the opportunities for community paramedicine, but also the program development, and then what are opportunities for shared learning or expansion scoping the work that they're doing and doing well with other potential partners. I'll turn it over to Nicole to introduce herself, and then I'll go.
So I'm Nicole, network specialist with Health Connect at Swatch. And yeah, I've just started kind of supporting the community paramedicine program as well. I do, lead the community-based workforce in monthly convenings and trainings and things like that. So I've known Sam for a while, but just specifically been integrating more with the community paramedicine program. And I was a part of their interview panel a couple months ago, which really helped me to, build relationships and learn really what the co-response is all about. And it's changing all the time, week by week. So it's exciting.
Great. Thanks. And Nicole didn't mention it, but I will. She has a background in behavioral health. And so she not only is supporting community paramedicine, but she also facilitates our formerly known as the Clark County Opioid Task Force, now the program
Prevention and Recovery Alliance.
The prevention. Yeah. And so expect, community paramedicine, behavioral health, and community-based care coordination they intersect in a big way.
Yeah.
And so my name is Eric McNair Scott. I'm Director of Community and Clinical Linkages with Swatch. And I think what I wanted to say is that the opportunity with Sam and the team at Clark Cowlitz Fire and Rescue has been to understand what community paramedicine can do, and also to separate out the different aspects of community paramedicine. So working with Sam has really been focused on community-based care coordination that is, people are engaged with this community-based care coordination through a deeply trusted agency, like the only government trusted agency, I would say, that really is trusted, which is Fire and Rescue. They are community-based workers. They're not community-based workers as we often think about community-based workers, such as CHWs or peers, but they work in community, they meet people where they're at, they can come to people's homes, and they can provide not only clinical scope, but highly specialized social work supports. And essentially at the social work supports, the overall aim, though they go about it differently, is the same: to assess risks across whole person care, physical health, behavioral health, and social needs, to work with the community member to share, here are the risks that we've identified. Are these also what you see? Do you want to work on them together? And to offer support to then enroll that community member in a partnership around a care plan, set priorities, and start working to connect to the resources to support the identified risks. And then critically, I think where we got to in this partnership is to have a way to document consistently, to be able to demonstrate outcomes in this territory. The social determinants of health outcomes is a new territory for consistent documentation and outcomes and reporting, and then to be able to report. And so we really saw the opportunity to test whether the community hub infrastructure could not only connect community paramedicine to the network of community health workers and other agencies, but also create a program and model for documentation, assessment, and reporting. That's how the charge model came about. It was a lot of experience on Sam and his team's part that led to the development of the charge model. And just to put this in context, we went live with the charge model 5 weeks ago. So,
Oh, wow.
I mean, January 1st, really, we've been working on it for half a year before then to develop it, working with care coordination systems and Clark Cowlitz Fire and Rescue, and having a test environment that went on for months while we were working out the glitches. But it's been live really for just over 5 weeks. So this is an opportunity, that's new. We're sharing something that is continually evolving, as this work has been all along.
Okay.
Sam, do you want to add anything to that?
Oh, I could add so much. Yeah. So again, within this model, I think, again, coming into the program and trying to figure out kind of what our needs were at the point, we really came at it initially with a very, again, it was probably overly clinical. It was a very kind of broad, almost like an outpatient type of setting kind of thing within the forms we were requesting and trying to build, and looking at the assessments we were doing, our treatment planning we were doing. We really, again, the scope was a little bit too big, I think, on our part when we initially did it. And it really overcomplicated some of the visits we had, because it was just too much for some of the folks that we were working with. That's not what their needs were. So we really found it was becoming a barrier to it. Within that, our data collection, again, really was, I don't want to say it was more anecdotal, but it really was based upon notes versus kind of tracking. And so some of that was really lacking, which we really wanted to bolster up. We knew we were doing a good job. How can we figure it out? At that point, it was myself, and then we had a community paramedic join. And then we also have a fall program that started within that, who is not really part of CARES, but essentially they are. They're a different program, but we all work together as one. And so another issue we're having too is we were very informal with the program, especially with delegating who's doing what and why and the needs. A lot of that was, I can yell across the office because they're right across from me, and I can go that one. We were doing a lot of those kind of meetings where we wanted to formalize that a little bit more of why somebody else was responding. Could you formalize that to almost have data backing why like the paramedic was going versus the falls person versus the social worker, or really back up the need for all three. And so working with Swatch, we were really looking at kind of those assessment pieces, the screening tools and so forth, that we were sort of doing informally over the phone at the point, or doing just by assessments in different skills, whether it be the paramedic doing an observation of someone, whether it be me kind of asking about every, the social determinants of health and things like that. And so within the charge model, it really broke it down very simply into a few questions that we're able to kind of gauge and start building from, that if we need to do the larger clinical assessments, the larger medical assessments, the larger falls assessments that we have, we're able to get to those and still track kind of what we are doing and why we're doing it. I think it's really, I've enjoyed the tool. We've also been able to kind of figure out when the best timing is to do that, how to do that. And then that really is looking at even how do we open up a client and how do we close a client. A lot of this is driving those things that were sort of ambiguous in the beginning that have become a lot more formal, and especially with Nicole's help of really kind of solidifying, and trying to really kind of capture this data. This is what it looks like. How are we getting more of it? Do we need less of it? And those kind of things.
Okay.
So I mean, that's sort of a history of kind of how we've come to this. I definitely foresee probably will change and adjust accordingly as things change more, and we're looking to do another program kind of in conjunction with our CARES program now too. So that may open up more avenues. I don't know yet. We'll see when that gets developed. But it's been nice, and it's once things are working good, it's kind of cool to kind of see how it is. Now it's more of just training and making sure myself and the other two members really are completing it correctly, just so we can start really pulling more accurate data. Gotcha.
Okay.
So I think that the benefit here is that, oftentimes in this work, we talk a lot about what we're trying to do and what we're trying to achieve. I think we've set the table pretty well. And so probably the biggest benefit, Martin, is for us to actually have Sam share a screen and walk you through the interface with CCS using the charge model. Sam, are you prepared to do that?
I am.
And the CCS, Eric, can you remind me what that stands for again?
It's Care Coordination System. So it is the data platform that Becky and all the ACHs have through the Department of Health partnership.
For the hub.
For the hub, right?
Okay, gotcha.
Yeah, we found, and again, I mean, initially when we jumped on the system, it really wasn't built for community medicine or community paramedicine. So we added some forms, we adjusted some forms. Again, some of them were a little bit way too much. Some of them we needed to kind of adapt a little bit more. So this really is kind of a combination of a couple forms that we've had in the past that have kind of slowly evolved kind of over the duration of the needs, and really looking at when we're working with clients, kind of how we can get the data, get it in a timely manner, and get kind of what's needed without bogging some of our clients down in, you know, hour-long assessments where all they need is like Meals on Wheels. That's all. I need to go over everything else. We'll ask it, but maybe we don't have to do such a formal setting and so forth.
Yeah. Okay.
Right, so give me 1 second. Just want to make sure I have the right one up.
And so a question for you, Eric. Given, you know, that Becky is just, you know, getting started on building the hub here, would that, you know, using the charge model, would that have an effect, or would it make a difference if we don't have the CCS set up, you know, as the hub for us currently?
I think I'd have to look at it a little bit more. You all do have CCS.
Yeah.
You've got it set up. At the risk of oversimplifying, I think what we have here with this model is a model that it's ready to go out of the box right now. We've gotten to that place. So if you have CCS and you have partners who would be interested in using the charge model to support their community paramedicine work, it's not the actual technology piece is already done. It's just a matter of getting access and getting them in there, you know, doing some training so that they're using it appropriately. But I don't think there's much more than that. And I will just say before Sam launches, the benefit here is that when Sam meets somebody out in community, he creates a community health record. It's the same system that community health workers are using when they support somebody and they have a community health record. And one of the benefits that we've always said of a hub is to put the experience of the community member being helped first. And the community health record can follow the community member. So if Sam starts with somebody through community paramedicine, and then 6 weeks down the line has supported them with some of their most acute needs, but they have continuing longer term needs, Sam can easily use the hub to connect that person to a community health worker through a warm handoff. And the community health record transfers over so that the community health worker then can build on the community health record already in place, doesn't have to start over, re-traumatize. And there's also that connection with Sam and the community health workers. So there could be a kind of an informal or even formal care team model to support the person, which is just a basic benefit of a hub. Yeah. But to your point, you're all just really getting going with it. I think it's pretty much an out of the box situation where if you had community paramedicine partners to whom this made sense, it wouldn't be a big lift to get them started on it. I'll turn it over to Nicole because she's really our CHR expert on that one.
Yeah, no, I think you covered it. I mean, I think it would just be starting the users, which we could definitely support getting them set up with user accounts, and then it might just take one training, you know, maybe an hour to just, you know, show them around, show them how to use it, and the chart screen, as you'll see, it's pretty simple and intuitive to use. So,
yeah, I think the biggest thing with this one is once you get this, you might have follow-up kind of assessments or things you'd want to do and how you want to track those. And those are when those get a little bit more kind of individualized to your program, or what the needs are and so forth. Like with our falls program, we have a specific falls assessment that's done that gets tracked in there and so forth. So, and you may have different requirements of other forms that are needed too. So,
okay.
Yeah. Do you guys see the Karen test screen right now?
Yes.
Okay. So again, as a general, this is kind of just our dashboard of what usually this is filled out a little bit more, but it is a test client, so whatnot. We do a couple different things, and within the system, there's a couple different ways of reading things and tracking things. So that is probably the biggest part of training, is understanding kind of what buttons do. And I'm not sure, Martin, are you familiar with the system at all?
I'm not.
Okay, so if I go too fast or forget something or skip something, please stop me. Sometimes I forget because I'm used to doing it. I know I've had this even with we have a new community paramedic who started, and I'm like, oh yeah, just press the one button. And she's like, I don't know where that is. So I'll try to kind of go over it just in general, what it looks like in general. So you have a contact tab, again, that really shows any contact that is documented using a contact, in other words, date, time, and so forth. This does not include notes or anything else. You could do notes and forms and stuff like that. This is strictly contacts. We have checklists, and these are kind of a variety of different things that have been built in there. Anything from, these are the ones we use primarily as initial adult. We use CP visit or community paramedic visit. And there's a health risk assessment one. Those are our primary ones that we're using now. Those can be individualized and adjusted kind of accordingly. Our initial adult is our charge screening tool. It's just what we've called it right now. And I'll go into that in a little bit. Pathways, this is the section that'll show of what actually the work to be done. And the one thing that we were doing before is we would maybe help someone get set up with Meals on Wheels. Keep on using that example. We would do a note about it. We would write it down. They would be satisfied. We'd be happy they got their services. And the only way really we could track that was going through notes and anecdotally. So this one is a little bit better, and I'll show you when they pop up once we do it, kind of what it looks like and how we can then track it via the pathways model.
Can I just say something really quick there? If you go back to pathways, correct me if I'm wrong, but you don't see any pathways here now because Sam's going to walk us through the whole assessment with Karen test. And as a risk is identified, a pathway to support that risk will be identified as well. And that will populate on this screen.
Okay.
But there are several, and we don't even use most of these. The community health program and the pathways program will use a lot of those. And if we need to go into that, I'll let Swatch kind of talk about that. We have a tool section, and these are some of our assessments and so forth. So we have everything from PAMs. We have a care plan that we originally developed that we actually modeled the charge program on. A lot of the things that were on there, we sort of just kind of adjusted. We have discharge, drug screening, again, our fall risk stuff that we have in here. PAMs, our PCAMs, our PHQs, you name it, all our clinical tools, assessments, and folders. Some of these we built specific just for our program. Some of them, like the study program, some of them we built, or some of them were already there. So again, there is some adjustment to be had within assessment tools being used. Again, our biggest thing was really getting bogged down in so many assessments that we couldn't actually get to the details of what we were doing. And so we really want to kind of back up a little bit with that.
In this tab, Sam, for the tools, if they're, they do a PHQ-9, on me, for example, and then, I'm on the program for say 6 months, do they redo the retest with the PHQ-9, or is it just like a one time? And if it does, if they do redo the PHQ-9, say a month or 2 months from now, does that kind of built on from the last assessment, so you're able to kind of compare the scores?
Yeah, we can. So again, within our PHQs and how we're using them is we may do like the PHQ2 initially with some folks if we're kind of concerned. We have a lot of folks that are coming right out and be like, I'm in therapy for depression and so forth. I have these feelings. We may not necessarily do a PHQ at that point since it's documented. Our use of it really is to see if someone is feeling that way and getting them to kind of identify with that, and we'll go over that. We could do follow-ups. We don't do them as much once we do the first one, especially once we link them to a service.
Right.
But it's the ability to do it, and it should automatically keep the score, and we can kind of go from there. Kind of what
awesome.
We can also share those if we do have a release with one of like their behavioral health agency. We can definitely share those with them, but a lot of times, we've done it in some folks where we've done the PHQ, excuse me, just due to some folks that we know are depressed that are showing it, and we may do it just to kind of gather that information and make sure we have it down so we can really make a more informed approach to what we're doing.
Okay.
Archive is really just things, once you're completed, they go into here and they can be closed off pretty much and
Mhm.
need to redo them, then you have to restart them.
And then those can be, patients that graduated from the program per se.
So the archive, yeah, it could be, but these are the actual tools, pathways, or checklists. These are the
Gotcha.
things we've done that can close out in archive. So these
Okay.
are not necessarily the client, but just the things we've done with them.
Mhm.
Let's say they did a pathway, they completed it. We don't want it on their active list, so it archives. We'll go here.
Okay.
Our central note function is all the contacts, the information from the contacts that may be in here, but it's also notes that are attached to different forms that may not, quote unquote, be a contact. We use this a lot, at least in our program, as almost like a guide and a timeline of what's being done. So you can sort of keep track. Like this one, again, this is a test one, so it doesn't look as good, but you can see client referred to Meals on Wheels. There's a note and done. Kate did that one. So again, it's just a way of tracking kind of the notes, and then a lot of these notes then attached, as long as you can see, are attached to different things. So they may be attached to an intake, a social service referral. And we'll go and I'll show you a little bit kind of we do these. I don't know if any of these are actually open since the majority are probably closed. There's the messages, which we don't typically use as much. There's tasks that you can be used. There's care team approaches that can be used within larger, if you have more than, if you have a larger organization with multiple people. We don't use this because we have our people, our staff as supervisors, so we don't necessarily use a care team. Hopefully in the future, we'll be using this function more with other programs that deal. Consult notes, we don't typically use this one either. Timeline again. And then our document section is a great way. You can upload anything up to the system. We upload intake forms, release information, hospital notes, discharge summaries, and a variety of other things that we can actually then go over and just kind of document with them.
Quick question for you guys, Sam. And this might be, it just popped up to my head right now when you were going over the documents and the discharge information. Do any of the fire departments that you guys work with use collective medical by any chance?
So I have access to collective medical.
Okay.
We were working with it for a little bit. I didn't find it helpful, but that's more, I think, user error. We got set up with the program, but actually never got trained in it with our original community paramedic. And we never used it. So we're using, when we do stuff, we have some Epic access with the hospitals and some limited access that we're using right now. And then one of our other paramedics who does, a lot of quality control is able to do some QI for us too when it comes to the person. So
yeah, just curious.
Yeah. Again, our idea originally was to use collective medical. It just, again, it's probably user error. We just never dove into it more than just getting set up with it and playing around with it a little bit.
If down the road you guys are still interested, we're working to implement collective medical within our fire departments and testing it out. So if you're interested down the road,
I am definitely interested. I have my collective medical tab right up on the top right now. I log into once a month.
Great opportunity for shared learning.
Yeah.
Because that is one, our look at kind of, because we work closely with the hospitals, we have contracts with both hospitals here. And so really looking at getting more information, and our new community paramedic is really invested in getting the right and correct information from the hospitals regarding medications and that more than we have in the past. Which is hit or miss.
Was it hard for your paramedic to get access to Epic through the hospital?
We have a limited Epic access that we have to get individually through each hospital. So like I'll have a Peace Health portal and I'll have a Legacy portal. So those our original medic, we had one, what's the word looking for? They gave like one license to do it. So it took a while to talk them into giving us another one, opening up how we look at it. A lot of that had to do with our contracts and looking at readmit rates, because we're really trying to figure out kind of and get some quantitative data on are they going back to the hospital? So we had some pushback in the beginning. It's a lot better now than it used to be.
Yeah, and I was just asking that because we do, some of the hospitals that are in different counties, not all have Epic, but it's been for Walla Walla, they have access to Epic through Providence, but Becky had to fight pretty hard while she was there at Providence to get just one, not everybody has access, just one person, Cody has access, and she had to, fight for it pretty hard.
They're
So
protective of it.
yeah, and so the going back to collective medical, our thinking is by them utilizing collective medical, if they don't have access to Epic or any of the hospital's information, they at least have some information while they're going out to visit these people. So that's why we're going that collective medical route, but definitely working with those that, hey, if you're like Benton 4 here that covers West Richland, the hospital would be Catholic, which they have Epic, but it's they only one paramedic has access to Epic, and that's through the city of Richland, and that they fought pretty hard as well. So I was just curious on that.
Yeah,
And I think,
believe, yeah, it's been.
I think that could be something. That could be something, Martin, that when we actually have a meeting following this meeting across ACHs, and of course CROA, seems to me that access to Epic and that data sharing piece should always be high on our priority list if we're talking about advocacy.
Yeah, I agree with that.
Yeah, and it's been an issue since we started. So
okay, yeah, just curious. Go ahead.
We'll go back to Karen. All right, so looking at kind of our initial, so we get referrals from multiple sources. We get them from our own internal crews. That we have our fire system that they can actually make a referral in, and then we get the information. And we've simplified. We built a form within our fire system when they do their notes that they can fill out, and it's a really basic. I'll refer to community paramedicine, refer to cares, and the reasons why, and it's a couple drop down boxes. So it's really simple for the crews to do that. That gets automatically emailed to me, as well as I can pull a report on those. We can get them. We also get referrals directly through the system. The hospital has access to a link that they can actually make a referral to, and then it'll automatically populate and pop up as a new client within this system and the CCS system, which I absolutely love because it makes life easier for me. I don't have to open up for doing that. And or I can manually put them in from a variety of different ways. We get some referrals from a couple of our community partners. Sometimes we'll get a self-referral that has happened. Sometimes we'll get a pathways referral. Somebody's already opened in the system that just gets reassigned to us. So I do get referrals from multiple sources. Yeah, go ahead.
For those self-referrals, how to community members, how can they self-refer? Do you guys have like a tab within your website for the Clark Fire Department, or
no? Not with that particular one. With self-referrals, especially, like we've done presentations to a couple of our lower income senior homes and stuff like that about help and assistance. They're pretty much just calling and getting directed to me. I take down their information and I open it up in the system.
Okay, gotcha.
Yeah. So self-referrals, again, we're not there yet, just because because we also, again, don't want to get inundated with 100 people. Like I follow up on every single one of them.
Yeah.
So kind of see kind of who's referring, why they're referring. I also like to know kind of where they got our information from. Self-referrals tend to be within our own district, while some like our hospital referrals and pathways sometimes can be a little bit throughout the county out of our district. So we really want to make sure who's getting what through what.
Gotcha. Okay.
Yeah. But again, we get them. We definitely do some outreach, so we definitely get self-referrals. So so within those, typically what we'll do at that point is really let's say we get a referral from the crews. I'll put the referral into the system and it will open up, and then I'll assign it to myself. So I can assign clients based upon whether it be a community paramedic or a falls folks. I usually assign them to myself. So like this one, I'll assign it to me. It's already assigned. And then what I'll do is do an initial call to that person if I can get a hold of them. Within that portion, depending on what's going on, I could just do a very brief kind of history, description of needs and services. And if they want a home visit, are they open to it? And I can just do there, and then I can come in and do the assessment, or I can do this assessment right there over the phone and get all the information. I like to do, if I can, because then I can really dictate and look at kind of what services are needed. But sometimes that doesn't always happen depending on which client we're talking to and what's going on with them. Because we run the gambit of client and client where they're at. So we call it the initial result. This is really our charge tool though. So I'll go ahead and open it up. And we have it broken down into really a couple different sections, and we'll go over each really quick, just to go over it. Again, we always have our date that we're visiting. Let's say today, I'm going to do it over the phone call because this is my first time. And again, I'm at maybe employment, but we'll say other for here, and so forth. So again, we first have the really question about falls. This was one of our big one. A lot of our referrals and a lot of 911 calls are just folks falling for a variety of reasons. And we like to call them impactful falls, falls that we can assist with. These aren't falls because it was icy outside the day. The day that we had the big ice storm, we had a ton of falls from ice. Again, are they impactful falls? Not really, because a lot of them, it was icy. Maybe someone was intoxicated and they fell. It's really not an impactful fall, but we may reach out to them though for the intoxication and substance use versus the fall risk.
Right.
But we do go through them. So we do, 6 months, have you fallen any? We talk about worrying of falling. Do you worry about falling? Do you ever feel unsteady on your feet? This is a good one really to gauge where people are they afraid and so forth. And then we also get some different fall information. They may say I have a history of falls. I've fallen, several times over the past, I don't know, a month, year. I used to never fall. Now I fall every time I just get out of bed.
Right.
So this will really gauge when we'll really start thinking of kind of that risk. We also look at it from an environmental point of view when it comes to falls. Do they have getting around or concerns about getting in and out of the shower safety? We do a lot of people that do, don't have grab bars in their bathrooms and so forth. So we do install those ourselves. So that's one of our big questions. We talk about just cooking, cleaning independently, just those basic life tasks. And is there a place in your home that they've fallen more than once? We have folks that tend to always fall in the bathroom, or always fall in the bedroom. The bathroom is, of course, it's just a huge one just because most people fall in the bathroom and it's definitely difficult to reach them when they get there. And then we can put other information. Maybe they tell us they don't have any grab bars in there. We'll put that. Maybe they say I have grab bars, but I don't use them. Or I have a walker, I don't use it. I'm supposed to use a wheelchair, but I try to walk with my cane and I fall. So it could be a variety of other things, but these questions really are looking at then, they're really good for our falls program that does a variety of different things. Doesn't mean the community paramedic's not there, but it's just gauges to that.
So these are more like triggers, would you say, for follow-up?
These are all triggers. So every single one of these questions is a trigger for something to be done. The yes triggers it, the no will not trigger it. So again, this gives us a good way of not just identifying through these, but they actually will trigger open pathways where then we can actually start to do work, and I'll show you what those look like once they populate. Then of course we have our medication management. It's a big one for us, especially with our medical piece. We also have contracts to do medication education and reconciliation, folks. And so do you have any new or recurring acute chronic medical conditions that are not currently being addressed by a provider? So do they have a PCP? Do you have any trouble knowing which medications you take, why you take them? And do you have trouble obtaining and taking your prescribed medications as indicated? Then we may talk about, if we have a med list at that point, we may even go over the med list right here. Maybe they have a doctor, maybe who knows what. So we'll try to get as much information as we can within here. We'll also do the physical health, and this is really aimed at looking at our medical side. Do you have any chronic conditions that are unmanaged that you need assistance with? And again, this is worded in a way where, again, we have folks with a ton of medical conditions, but they're going to a doctor for all of them. We can check on them, and it doesn't negate our paramedic helping if they say no, but this just gives us, is there anything that you're not being seen for? And then do you need a doctor or primary care provider? We have a lot of folks that do not have doctors or refuse to go see them. And then we have how many times have been the ER in the past 6 months. And our trigger on this is 2. If they've only been 1, it's still an area of concern, but it won't trigger one of those pathways. And then we have just other physical health needs, which we always have those. And then our 2 social kind of behavioral health items. Again, do you have any mental health or SUD concerns? Are they saying they have concerns? Not whether or not, let's say our crews reported that they had, they were intoxicated when they fell. We're talking to them and they're like, no, I'm good. I'll put no, but I may in here put history of falls due to intoxication, or substance use. And if yes, do you need care? Do you need a mental behavioral health provider? They may say, yeah, they may say no. But we'll let them decide, even though I may put notes about why they said a certain thing that way. And again, for our social determinants of health and health-related social needs, do you have any issues meeting needs personally or for the family? And some of these we have here: housing, food, clothing, transportation, utilities. We have an other button that can trigger that we can write it in and so forth. And then we have, of course, our and then we have a follow-up date. Maybe at that phone call I scheduled for, I'll be out next Monday. Is that good for you? Perfect. And here, again, is when I talk about those notes versus contacts, I can put maybe the rest of the information down that maybe they said things that didn't not really pertain to these, but maybe there was just other things like phone numbers or working with that as well. I can put additional information in here that I can see when I go back on that timeline. So additional info. And of course, I spell check. I absolutely love it. So these will get processed. So right now, the system does take a couple minutes for it to kind of go through all the pathways. Today has been slow for me, so hopefully it will kick in right away. So we'll give it a minute. But going back to those central notes, again, here's that note I wrote, the additional information, and it's attached to that initial adult screening tool that we just completed, which you can go right back into it and read everything I just wrote, which is very useful. And that was the difference of the contacts, because you're not going to really see that in the contact. So what I typically do is after we do like a screening, I'll actually go in and do a contact where I do the date, I do the time that it has had this conversation. I'll do what kind of contact was it. I'll do the reason. Maybe it was a first meeting. Maybe it was just to gather information. I'll say completed assessment. I'd actually probably do a little bit more than just that, but for a second. And then what I'll do is I will actually attach this note then to that checklist that we just did and save it. And so when this is all saved, now I have a contact that you can actually record time, date, and all those kind of things. It's also in my central notes, so I can see what's being done, and it's already attached to the assessment, so I can go right back in when I need to. Yeah, go ahead.
Oh, no. I'm just agreeing with you. I'm liking the whole.
So, and again, this is part of our workflow that we've developed, especially with this new way of doing it. Was initially we weren't really attaching the forms to each note, and so we were duplicating notes, and it was becoming it was becoming unmanageable doing all that. And so this way is so much easier. You can see what's being done. It's quicker. You can go right to it. You have everything connected and so forth. So as I said before, all those in the checklist, all of these yeses triggered something different. And we call them pathways. And so all the pathways then start to look like this. There is one currently that's not popping up right now that we're doing manually, but we're working on that one. So again, typically we're only using medical referrals and social service referrals for anything from the falls to medical to social needs. So one of them I know we had said they needed a behavioral health person, so we'll click on that one. And it could be a variety of different things that they want to work with at the moment. So, and again, first one, do they even want to work on it? We know that they are using when they fell. We talked to them, they don't want to work on their drinking, they're not there, which is fine. Maybe they'll get there, hopefully they will. So that one, I'll say, is that a client priority? I'll say no. And that's all I need to do. And what this form will do, and I'll show you when we do a yes one, it will automatically close out and go away back to the archive section. Doesn't mean you can't reopen it and do another one. Doesn't mean we're not going to try to get them to a place where maybe they want that behavioral health or substance abuse. But as of right now, they're not going to work on that. And so I'm not going to push them yet on it. I'll push them later for sure. Yeah, go ahead.
And then that moved to the archive you mentioned, right?
Yep, that will move to the archive. I don't know. Oh, maybe I didn't delete all the old archives. I thought I did. Okay. But they'll look like this, either finished and complete, finished and complete. I think this is what we just did. Yep. So this is what we just did. So it closes it out, says decline further service in this section and so forth. And again, just because it closed incomplete doesn't mean we're getting penalized for it. It's just we're acknowledging it's not a priority for the client at this point. But what they did want help with is maybe they wanted help on their med management piece. So we'll go into our med management section one. So we have it already set up. It's a client priority. Referral type is med management. Are we doing a medical care referral other? Typically it'll be our falls program. So maybe I'll do our FERP program, which is our falls and education risk reduction program. And what do we do with them? So at that time I went over to the home with our falls person. We talked with them, we met with them, we installed some grab bars, we talked about appropriate walking, appropriate standing. Again, we're not OT or PT, even though we have some experience in that, but we'll go over some really basic things like that rug probably should be moved because you keep on tripping over that every day. And we may even move it for the person. So we might say education provided. And that was when we went out on the Monday, we went out there. Sometimes you got to do up on those and then completed. I completed it on the Monday and we verified it with our client because we were there. What did they do? They were assisted, maybe scheduled an appointment with the agency. They met at an appointment. They did. And here we may even write down what we did. We may have, moved carpet, moved rug, installed feedback bars, et cetera, et cetera. But let's say I didn't finish it yet and this opened. It will just stay open until I finish all sections of it. It will stay open and it will continue to remind me that it's there. So that's only, because I have a future date. Whoops. And it won't let you save in the future. So that one then will go archive because we completed it.
Right.
But during that time, I didn't talk about anything. We might have talked about some of these with the person, but I didn't get to them. Maybe I didn't get to, we talked about transportation. They were like, no, I want to still do it, but I'm not there yet, or I'm ready. So we'll keep it open and it will stay open like this, which is fine. And it reminds me to go back when I'm talking with them to do that. Maybe I also did a couple other things. Maybe during that time, I also did the PHQ too on them. So I could always go back in here, do PHQ 2, complete this, and it will be on their chart also. But that really dictates with this one, really what we're doing and kind of gives us more a guideline versus sometimes when we're putting it all in a note that we're doing a couple different things and who's going to go out. Well, before it was, they talked about falls. I have it in a note. So I'll send my falls person out. Again, exactly what we're going to do now, but we actually can track it now, but what the priority needs are. And the one thing I really do like is is it a client priority? We meet with clients, and this is this top right here. We meet with clients a lot of times who have so many needs, but they're not working on them. They're not going to work on them. I still want to make sure we're tracking it and opening up what risks we are identifying with them. I will always talk to somebody about the risk, that substance abuse one. I will talk to them about, and they're maybe not ready to change yet. They're not in that, stage of change and all of those kind of things. I will work with them to hopefully get them to that place, and hopefully they will. But it may take a couple of visits, and it may take more than me. It may take when we're closing them, maybe they're drinking less. Maybe it's some harm reduction we're doing with them around when they are drinking, that they're not going, mowing the lawn because they fell, while doing that when they were drinking. So we will put that down as best as possible in some of our notes and so forth. But if it's not a priority area for them, well, we can note that it's not a priority area. And again, our biggest thing was making sure that those no's and those incompletes aren't negatively affecting the program, but just giving us more data on what people are willing to work on and what we're identifying as risks within talking with someone during the assessment period. And again, that is a simple screening tool. And within the tools, you can add more different ones that if you want to do more of a further one. But again, what we were doing is we were meeting with folks and trying to get these larger assessments done that really didn't either pertain to them, or they weren't ready to do, or they weren't in a mindset to do. We meet a lot of folks who may be experiencing some sort of dementia, poor historians, who are going through crisis as they speak, who just got discharged from the hospital and all they want to do is, just not go back to the hospital. And so we really are gauging within our department, who's going in and meeting with the client and what's the best use of our resources here, since we are a small division. Did I miss anything, Eric, within this program?
No, that was really comprehensive, Sam. Thank you so much. That's a really good review. I want to give Martin a chance to ask questions, but also Nicole is in there all the time. Is there anything you would add?
Every time I thought of something to add, you ended up going over it. So, yeah.
No, I go ahead, Eric. Sorry.
I'll just briefly say that from my perspective, partnering with Sam and Clark Cowlitz Fire and Rescue, I think what we've seen is that, you know, those risks were identified on the front end previous to this, but there just wasn't a systematic way of keeping on top of them like there is now, not only to support the community member, but also to track outcomes and reporting for the individual risks. So, and I think, Sam, that's been one of the big changes with this model.
Yeah, I mean, we've talked about it a lot, especially within our programs. I'm trying to think. I'll go to the profile really quick, just because I always like this one. You know, we even had kind of what information we were tracking within this, and this is just a profile. We have referral source, who's referring folks to us. We're tracking data on that. We're tracking incident numbers when we get them from our referrals. I don't want to go out yet to the other page. One of them is where our referral form has different things that we're tracking of why people are referred to us, reasons, needs, and so forth. We also kind of track different things, whether or not you can inactivate someone. Doesn't mean you can't reactivate them later, but we really are trying to do a better job of looking at when someone is active versus inactive. Also, when someone's just referred, maybe they're not ready for us to come over yet, but they're talking with us. What does that mean? Are they enrolled at that point? Are they giving us permission to do things? We're still giving education and resources over the phone. We want to make sure we're tracking all of those things, and tracking just other data if we do have it. Again, sometimes it gets a lot, and so we're really trying to kind of pick which ones are going to be the best to track, which ones are needed for future sustainability, as well as not just data collection, but data collection for us as well as the hub as a whole.
Yeah, awesome. And is there, I'm guessing no, but is there any cost to be on the system as far as like the fire departments to be part of this?
There's not. So this is, you know, we've always seen the hub as a public utility. And the key is sustainability for the partners, for the programs, for the community-based workforce, and the hub sustainability is part of that. So the hub, of course, as you know, ACHs, we're working around sustainability strategies all the time. One of the opportunities, and this is just one of the opportunities for sustainability, is because this system does track outcomes and reports on outcomes, it's also connected to an outcome-based payment mechanism. We haven't put it in place, but we're going to be testing that with Clark Cowlitz Fire and Rescue this year. So this is preliminary, but this is just an example, right? So if we can get some data, for example, on falls, we know how much it costs to, you know, respond to falls and to transport to falls, and it costs X, let's just say $1,500. And we, not only for the community benefit, but for cost savings, we have stakeholders who are willing to commit, you know, $1,000 for a successful outcome, representing a cost savings of $500, but also then that's funding that goes to Clark Cowlitz Fire and Rescue. And within an outcome-based payment model, part of that outcome-based payment would go to covering the hub operations costs as well. So, you know, built into that model is sustainability for the partner, for the program, and for the hub network. And that's just one approach. You know, other approaches are that fire and rescue, ACHs, hubs, others can seek money, and then having this data resource and platform makes a much stronger application for funding as well.
Yeah. Okay, cool. And I see that the PAM on here, the PAM level. Have you guys been are you guys using the PAM, Sam, for any of the work that you guys are doing?
We were using it initially. We haven't used it as frequently anymore. Then we were using the PCAM more frequently than that, just because it's a little bit more directed by the clinician versus the client. And those are just ones, again, in our workflow, we'll probably start investing more in kind of what we're doing with some of those separate assessment forms.
Okay, cool. No, I like this. So if you can share the recording with us, Eric, once you get it converted and everything, because Becky sent me a message while we were meeting that she couldn't find a hotspot to connect. They're out like in Pomeroy or Dayton, so it's pretty rural out there. So you can see the recording, because a lot of useful information on here. I like it. And I, want Becky and Sharon to see this as well, to see if, hey, I like it better than what we're using now, just because you can build in, the different assessments, things populate in other tabs, the pathway. So it has a lot of functionality, and more that you're able to see what the outcomes are for those people that you are targeting. So yeah, if you can share that with us, Eric, that would be awesome.
Absolutely. Yeah, happy to do that. And let me just geek out with you for a second. One of the things I'm excited about right now, and it's really preliminary, but I know Clark Cowlitz Fire and Rescue is looking at it as well. When at the beginning of the Medicaid transformation project, I was really focused on the opioid response. Continued to be. I've just expanded the work. But there's a real opportunity here for creating access to medication-assisted treatment through EMS and fire and rescue. It's one of those, like, it's just right?
Yeah. They see them.
Right.
They know them.
Yeah, and a lot of those folks that they're in withdrawal and they're in overdose, they might be at that point readiness to change, to get inducted right then and there. And then because it's a hub supported program, there can be a follow-up and a referral, a warm handoff for somebody to support that person through recovery.
Yeah,
it's not on Sam. Sam and the community paramedic can do that acute response, maybe the first few. But then there's that handoff, that long-term piece. And I think when we think about hubs and community-based care coordination, it is, how do we network across multiple agencies and partnerships to provide that continuing care?
Yeah.
And how do we not get caught in different systems that fragment and silo it?
Yeah, and more, as I'm working with the different fire departments, putting an emphasis on building the resources around the fire departments. Because like you said, now, I was meeting with Sunnyside Fire Department the other day. I was introducing them to comprehensive healthcare, which they're behavioral health and SUD provider. And they're literally like blocks away, and the fire department didn't know, that what services they offered. I'm like, hey, this is a good way to connect you guys. Now there's a resource here. So yeah, there's definitely the work to be done, and things for improvements, which what we're slowly getting there, and having meetings like this and sharing what you guys are doing is very useful for me as I'm going out in the community and working with the different fire departments.
Yeah, and it takes a lot. I mean, even our own fire, we're continually doing training with our guys here. Some still, even if they don't know the resources, they know to contact us, and they're doing that a lot more frequently than even a year ago. And we've been doing this for about 2.5 years now. So it's definitely a culture shift within fire agencies to look at non-acute services. Firefighters have a different culture. And so there's a bridge there that needs to be done still. Even you need a champion in each. Luckily enough, we had one of our captains here and our chief who were really champions of what we were doing, and really were able to get the show off the ground. And we'll need that in each fire department, just because there is some resistance. It's changing.
Yeah. And I think kind of having it come out of an ACH is also a benefit, because there's really, we're not competitors with others. We're just really trying to build bridges to take care of the community members and have them not fall through the cracks, and not have them, be a burden to the healthcare system when they don't need to be. So yeah, no, I really enjoyed this meeting. So thank you guys.
Yeah. Thank you. Thanks so much, Sam. Thanks, Martine.
Thank you all.
We'll end it here. It's 2:00.
Yeah.
And I will share out the recording.
All right. Thank you.
I appreciate it. And if you have any questions, Martin, please feel free to reach out.
Yeah. We'll do.
Okay. Thank you all.
All right.
Bye. Thank you.